interested in. So we'll start without much further introduction. So the agenda for the day is very simple. We are going to talk about some of the common drugs that are used in pulmonary hypertension of neonates. We will briefly discuss how they work. I know that there's another upcoming class by a good friend and former junior of mine on the pathophysiology of pulmonary hypertension, particularly in preterm babies. So we won't steal his thunder. We'll mainly focus on the treatment of pulmonary hypertension with drugs in term babies. And we won't probably focus on inhaled nitric oxide because you already had a session on that. We'll also briefly review if there is any evidence for their use and see if we can have any rational approach to using these drugs. There are multiple drugs and different people use them in different ways. The protocols vary from place to place, but we'll see if it is possible to come to a rational approach to treat pulmonary hypertension using many of these pulmonary vasodilators. So just briefly about the pathophysiologic basis of these drugs. How do these drugs work? So you probably have seen diagrams of how these drugs work. But before we go into that, let's just briefly review what we want to do in pulmonary hypertension. What do we want these drugs to do? So we primarily want these drugs to reduce the afterload. That's the primary topic for today, pulmonary vasodilators. So when you cause pulmonary vasodilation, you are essentially reducing the workload on the right ventricle and improving the flow, the pulmonary flow, so that oxygenation is better. You want to optimize right ventricular filling, also left ventricle, I guess. So that may involve volume loading, that may involve some lusitropic agents. So something to improve the filling of the ventricle and contractility, and also the systemic circulation. So we also want to support the systemic circulation. In fact, that is a key component of treating pulmonary hypertension nowadays. So the entire focus is not on pulmonary vasodilators, but we'll talk a little bit about the other effects of the drugs also. And at the same time, you want to maintain the systemic vascular resistance. Actually, you want to maintain the systemic blood pressure. So one way to do that is maintain the systemic vascular resistance. So, but my main focus is on pulmonary vasodilators for today's talk. The first thing that we're talking about. So you might have seen something like this, a diagram like this in many of the books, and it can be quite confusing because there are many players involved. Most of the action in pulmonary hypertension is taking place obviously in the pulmonary blood vessel. And when we say pulmonary blood vessel, we are talking about mainly two kinds of cells. The vessels have an endothelial cell lining, so we are talking about the endothelial cell, and outside it, or you could say under the epithelial layer, the endothelial have a smooth muscle cell layer. So these are the two cells that are the major players that are involved in the pathophysiology of pulmonary hypertension and also in the drug treatment of pulmonary hypertension. But we'll come back to this diagram and look at it more systematically in a minute. But essentially what you see in this diagram is that you are trying to focus on a couple of things. One is there is endothelin, which is a vasoconstrictor and also causes smooth muscle proliferation, which from what is described sounds like the villain here, right? And you have, on the other hand, you have cyclic GMP and cyclic AMP. Essentially both increase the, modulate the calcium entry into the smooth muscle cell and cause vasodilation. And they are both anti-proliferative. So these are the central players, right? Endothelin on the one hand, which is vasoconstrictor, and on the other hand, you have cyclic GMP and cyclic AMP, which are vasodilators and anti-proliferative. So by manipulating these using drugs, we can modulate pulmonary hypertension and its adverse effects. So now let's look back at the endothelial cell and the smooth muscle cell. So the endothelial cell has endothelin receptors on it, endothelin B receptors. The smooth muscle cell has receptors for the prostaglandins, prostacyclin I, also called prostaglandin I2, and prostaglandins themselves, prostaglandin E1, E2, and all that. And also endothelin A receptors. The endothelin A receptors mediate vasoconstriction. But ultimately, the action of most of these pathways is to increase cyclic AMP or cyclic GMP inside the cell. And that reduces calcium entry and actually will cause vasodilation. So how do we do this? So there are various drugs that act along various pathways. Cyclic AMP is produced from ATP, and the enzymes involved are adenyl cyclase, and the cyclic AMP is degraded by phosphodiesterase 3. So if you want to increase cyclic AMP levels, you have to either increase the activity of adenyl cyclase or decrease the activity of or decrease the activity of phosphodiesterase 3. So you're trying to increase the levels of cyclic AMP there. And cyclic GMP, on the other hand, is produced by soluble guanylate cyclase and degraded by phosphodiesterase 5. So again, in this case, if you want to increase the levels of cyclic GMP, you have to increase the activity of the guanylate cyclase or inhibit phosphodiesterase 5. So both will have the same effect. They will increase the levels of cyclic GMP. So that gives us a clue about what kind of drugs we want to use. The endothelial cell is actually one of the major roles of endothelial cells is producing nitric oxide. Actually, it used to be called endothelium-derived relaxing factor initially, and it's now called, we knew later that it is this endothelium-derived relaxing factor is nitric oxide. So obviously it is derived from the endothelial cell. And that's produced from L-arginine, and that's a process that requires oxygen also. Using nitric oxide, nitric oxide synthase plays a role there. And obviously, inhaled nitric oxide would act at that step. But we won't be talking much further inhaled nitric oxide because you already had a talk about it. Endothelin receptors, on the other hand, are two types. Endothelin A receptors are predominantly vasoconstricting. Endothelin B receptors actually increase nitric oxide levels. Bosentan is one drug that we use, and it actually is somewhat non-specific. It acts on both the endothelin A and B receptors, but the overall effect seems to be of pulmonary vasodilation. So it blocks both the good effect of endothelin as well as the bad effect because it acts on both receptors, but the overall effect seems to be of vasodilation. And then the prostacyclins, they improve the adenyl cyclase activity. So prostacyclin, prostaglandin, we'll discuss that in some detail. Milrinone, you know, is a phosphodiesterase 3 inhibitor, so it increases cyclic AMP in the cell and causes vasodilation. And sildenafil is a phosphodiesterase 5 inhibitor, so that increases cyclic GMP in the cell. So we'll go into these individual drugs one by one and see a little bit about what evidence we have, what do they do, and so on. So in some more detail. So prostaglandins are something that all of you must be familiar with because we use it a lot in critical congenital heart disease. And many centers also use it for pulmonary hypertension. And you know that there are at least a couple of forms of them available. We all at some point, you might have seen either in obstetrics or in neonatology, you might have come across prostaglandin E1, prostaglandin E2, both more or less equally effective, but cheaper. We more commonly use prostaglandin E1. Prostacyclins or PGI. So the prostacyclins are less commonly used. That's partly because of their half-life and availability and other reasons. So PGI2 has a half-life of only around 6 minutes, so it's very short acting. You will need a continuous IV infusion. There is hypotension with its use. Same as prostaglandin E1 or prostaglandin E2. And the other analogues of PGI2 are available with the longer half-life, which can be used IV or inhaled. Prostaglandin E1 we commonly use IV, but since you are more familiar with prostaglandin E1, I'm not, I haven't mentioned it on this slide. Most of us would have used it. These drugs, there is usually rapid development of tolerance, so they may or may not be effective for prolonged periods. There is very little evidence for their use in pulmonary hypertension. And this is a recurring theme you'll see when we talk about the various drugs, that there is very little evidence for their use. There have actually been a few RCTs, randomized control trials, of the use of these drugs. But many of them were in post-cardiac surgery babies, especially when they are trying to wean off inhaled nitric oxide or when there is incomplete response to inhaled nitric oxide. And in that setting, they have been shown in small trials, again, small trials, to be effective. And one other effect of prostaglandins is that they keep the ductus arteriosus patent. So if that could reduce the afterload on the right ventricle also in the setting of pulmonary hypertension. So it might help directly by pulmonary vasodilation, and it might help by other mechanisms also. So really not much evidence, but they, in some centers, I would say they are second line drugs after inhaled nitric oxide. Sildenafil we commonly use. Well, primarily because there is probably a little more evidence for their use. There was even a Cochrane review, I think it involved around 5 small RCTs of sildenafil, which showed that it reduces mortality in low-income settings. All those studies were from low-income settings. But overall, there were about less than 200 babies in all the RCTs together, if I'm right, if I remember right. So the quality of evidence was rated low. So not that much experience, but it's not entirely a new drug. We actually have a couple of decades experience with sildenafil probably. I mean, I think the first time I heard about sildenafil was when I mean, of course, we had heard about Viagra, but the first time I heard about its use in neonates was when a neonatologist, a well-known neonatologist in Kerala, got into trouble after using sildenafil. The baby survived, but he got into a lot of trouble for using it off-label. Anyway, that's a different story, but that was many years ago. So we have a fair amount of experience with sildenafil. And remember, that was oral sildenafil. Now IV sildenafil is available. Of course, it's very expensive compared to the oral form. But remember that when we started using it, even in critically ill children, in neonates, we were using the oral form. So I think many centers actually use only the oral form. I think we also use it a lot. We also have the IV preparation. But, you know, there are a lot of objections to using it in critically ill children who are NPO, using an oral drug, but we do find it effective even in those children. Not consistently, but, you know, in many babies. It is, like I said, something that needs to be further studied. But these drugs are very difficult to study because of a couple of reasons. One is that there is no clinical equipoise. If I believe that this drug works, I feel it's unethical to do a randomized control trial with one group getting placebo and the other group getting sildenafil. So that would feel unethical because I would feel that I'm denying one group of treatment that I think is effective. The other problem is that there is the multiplicity of drugs. So if you use sildenafil, but that baby is also getting other drugs, it is very difficult to say how much effect is due to commercial and how much is due to some of the other drugs. So unless the other babies are all getting some kind of standardized protocol, it would be very difficult to do a randomized control trial. Sushil, can you silence your phone or your laptop or whatever? Okay, thank you. The other drug that we know we use is Milrinone. Again, somewhat on the expensive side, but relatively easily available, expensive but available. And it reduces peripheral vascular resistance and pulmonary vascular resistance. And it has an additive effect with inhaled nitric oxide. So it also improves myocardial function. As you know, it is also inotropic and improves the relaxation properties of the myocardium. So it's lucitropic also. And the one major downside is that it can cause hypotension, or it can worsen hypotension if the baby is already hypertensive. So there are at least a few RCTs going on, including one multicentric randomized control trial, and one right here in our unit. It's a DM thesis, and right now there is no published randomized control trial on Milrinone use in pulmonary hypertension in neonates, but we use it because of theoretic benefits, anecdotal benefit, and a lack of choice that sometimes, because when the baby is sick and the other drugs are not working, you have to do something. Again, very commonly used low dose arginine vasopressin. We didn't show it on the diagram when we discussed the endothelial cell and the smooth muscle cell. And that's primarily because it acts on the systemic vasculature more than on the pulmonary vasculature. But in low doses, it seems to cause some pulmonary vasodilation, some fall in pulmonary vascular resistance. But the main effect is improving systemic blood pressure. So indirectly, it probably improves the hypoxemia by reducing the right to left shunt also. And many people swear by it. Again, very limited evidence. In fact, we were wondering whether to do a randomized control trial on arginine vasopressin first before we settled on Milrinone. The one reason we did not use steady arginine vasopressin was because many people in the unit felt that it works. So it would be very difficult to do a study then, because the babies in the placebo group we wouldn't be able to give it, or we would end up contaminating the study by giving it to the placebo babies in the placebo group also. So again, no evidence from randomized control trials at least, but observational data are available, and very limited, really limited evidence, something that really needs to be studied. I really hope someone is going to study this also next. Bosentan is relatively inexpensive, so endothelin receptor antagonist. And advantage is probably that it's oral. Advantage because it's not very expensive, because it's oral. It's an oral preparation. Disadvantage, of course, is that in critically ill children, again there is a concern about giving it orally. There are other analogs also being studied in adults with pulmonary hypertension and older children with pulmonary arterial hypertension. But the pathophysiology may be different there, and we cannot assume that it will work in neonates also. And somewhat conflicting evidence on bosentan so far. I know of at least 3 small RCTs. In one, it improved short-term outcomes like things like oxygenation index and pulmonary arterial pressure, which are not really relevant clinical outcomes. They are more like surrogate markers for clinical outcomes. So I don't know if I would take that at face value. and really small RCTs. The first one was about 47 children. There was another study that looked at sildenafil with bosentan versus bosentan alone and showed some improvement again, about 100 babies in that. And in another small RCT, which was only about 20 odd babies, there was no difference in outcomes. So again, if someone wants to do a study, these are all excellent options. Apart from the difficulties in studying them that I already mentioned, the lack of clinical equipoise and the complicated drug regimens that these babies are often on. The one other problem will be getting cases in the unit. So unless you are a really busy unit, you may not get enough cases with pulmonary hypertension that meet your criteria, because you may not want to include children, for example, with congenital diaphragmatic hernia, or you may not want to include preterm babies because that pathophysiology could be different in those babies. So after all your inclusion and exclusion, very few babies meeting enrollment criteria for you. So it's very difficult, but all the more reason to do probably a multicentric randomized controlled trial. Oxygen is, of course, a pulmonary vasodilator. We are not talking about it today because all of you know oxygen. Apart from what we know, I mean, it directly does cause some pulmonary vasodilation. It's also good to remember that NO synthesis requires oxygen. So maybe that's one of the ways in which it works also. And hypoxia, I have an annotation request. Abhishek, do you want to answer that? Should I approve?
You can check.
Okay, right. And as you know, hypoxia increases VEGF secretion, which causes smooth muscle proliferation. So hypoxia is bad. So in that sense, also oxygen therapy may benefit these babies. But that's something we already know. And of course, if you really are looking to study further, there are no lack of choices. There are anecdotal reports of many other things working. Very often we are impressed with reading case reports. Epinephrine worked, or epinephrine worked, or hydrocortisone worked, or a combination of drugs worked. But I really would seriously suggest that you have a systematic approach and stick to it. It probably matters less what the systematic approach is, as long as it's rational. Because it's like necrotizing enterocolitis. It has been shown that if you have a feeding protocol, you have less necrotizing enterocolitis. It doesn't matter what the protocol is. If you have a protocol, your outcomes improve. So I would say it's somewhat like that, that if you have a, I think some more babies would probably do better, especially given the lack of evidence. There is going to be some subjectivity in your protocol, but I think we should have, I mean, one rational thing to do would be to stick to some protocol. But we will see if we can. In fact, we had to evolve a kind of a standard protocol because we had to do an RCT on Milrinone. So we had to make a standard protocol without Milrinone in it. And I have modified it with Milrinone included for this talk. But, drug therapy isn't everything. And as we know, prevention is better than cure. And the management of these babies should be really holistic. We need to avoid all the precipitating factors like pain, noise, bright lights. The excessive stimulation caused by all this can worsen pulmonary hypertension. And it is very common to see people speaking loudly near the baby with pulmonary hypertension, especially during handover times. People not paying attention when the baby is desaturating. The effect of hypoxemia can be quite long lasting. And there is some evidence that when hypoxia recurs, the pulmonary hypertension rebounds much more. So we have to be really careful about those swings in saturation also. The dips in saturation intermittently. and respond fairly promptly by change in oxygenation, by change in FaO2 or other things. We have to take care of or prevent infection or treat infection. Again, prevention definitely is better than cure when it comes to infection. The management includes management of asphyxia, hypoglycemia, prevention of cold stress. Often babies, even during short transfer from the labor room to the NICU, get cold, and that has been a problem for us also. But very often we focus less on that and focus more on all the drug therapy inside the NICU. But that would be the wrong approach. I agree that if you prescribe a drug, Sun Pharma or someone else is more likely to sponsor your conferences. But if you manage pain in the NICU or manage hypoxia in the NICU or cold stress in the labor room, nobody is going to sponsor your conference. But those are equally important. And another thing that we need to focus on is the ventilator management. We will maybe talk a little bit about it in detail. But keeping the lung adequately expanded, not hyperinflated, not underinflated, that's a key concept also, because when the lung is expanded, the vasculature is adequately expanded. And the pulmonary vascular resistance, we all know from our basic science classes that pulmonary vascular resistance is least when the lung is at functional residual capacity. So that's something that we should aim for. So these other factors probably deserve an equal amount of attention or more than drug therapy in pulmonary hypertension. But our focus today is on pulmonary hypertension and vasodilator therapy. So I will try to see if we can have a rational approach or a rational framework for the use of pulmonary vasodilators. So essentially like a flow-driven approach, a flow diagram for the use of pulmonary vasodilators. The general measures that we already spoke about a little bit, we'll talk about that. We also can talk a little bit more about oxygenation and ventilation before we talk about the pulmonary vasodilators as such, and also systemic circulatory support. So that's the general approach to the problem. We focus on general measures, oxygenation and ventilation, pulmonary vasodilation, and systemic circulatory support. And in general measures, we already said that we need to minimize the stimuli that can worsen PPHN. So we make sure the environment is quiet. There are eye shields, ear muffs for the babies. If you have to use analgesia, fentanyl seems to work a little bit better than the other opiates. And midazolam has somewhat gone out of fashion nowadays because of its, the higher adverse effect profile. And we almost always avoid paralysis unless we are really stuck. And most babies need some nutritional support. That usually means short-term parenteral nutrition. But once this baby is stable, we try to start at least trophic feeds. About oxygenation, there is no consensus on the SpO2 target, but some have suggested 90 to 97%. I think 90 to 95% is also fine. Because these are term babies we are talking about. We are not talking about preterms with pulmonary hypertension here. Slightly lower cutoffs should be acceptable in diaphragmatic hernia. We also follow tissue oxygenation with pulse oximetry, your PaO2 in the gas, lactate in the gas, and some units use near infrared spectroscopy. We don't. But if you have it, that's fine. We generally target carbon dioxide at a somewhat higher level for these babies. We usually accept up to about 50. Some units accept up to 55, as long as the pH is above 7.25 or so. In congenital diaphragmatic hernia, we often accept up to 65 carbon dioxide, as long as the pH is more than 7.2. The idea behind about this, kind of permissive hypercarbia and the relatively low target, especially in congenital diaphragmatic hernia, is that we limit the tidal volumes and peak pressures to minimize lung injury. Surfactant therapy is used, especially in meconium aspiration syndrome, but not routinely. And we don't know, it does contribute to a reduction in pulmonary vascular resistance. But of course, it's not the primary therapy for treating pulmonary hypertension. And we use it selectively in most of our, as you know, most of our babies with respiratory distress syndrome or meconium aspiration syndrome nowadays don't get surfactant. And it's of course not useful in congenital diaphragmatic hernia. So like I said, about 90 to 97% for the SpO2 and at least 40 to 50 for the PaCO2. And often overlooked is the systemic circulatory support. And this is again a little bit controversial, but generally speaking, most would agree that if it is under 35 or so, the mean blood pressure, that would be hypotension in a term baby. And we tend to, ideally, if you can keep it towards the higher end of normal, maybe around 45 or higher in a term baby, that would be good, because then it would reduce the right to left shunt and hypoxemia. So we need to support that systemic blood pressure. And we use maintenance IV fluids, not many boluses though, unless there is some evidence based on your targeted neonatal echocardiogram or something saying that there is hypovolemia or a setting for it. Most guidelines would agree that in a critically ill baby, you can keep the hematocrit above 40% or so, cells used, but judiciously. And not much evidence for what should be the first line inotrope. We currently use dobutamine, but we'll come to that in a minute. So when you talk about term or a late preterm infant with pulmonary hypertension, and not counting congenital diaphragmatic hernia, because that management would be quite different. We're not talking about that. Let's say we're talking about meconium aspiration syndrome or asphyxia or infection-related pulmonary hypertension in neonates. So you will end up with 2 or 3 broad categories of neonates. So one would be the, well, we first need to confirm it. We do an echocardiogram to confirm it. And we take care of the general measures and the ventilation parameters that we mentioned. And then we will end up with, some babies are going to be relatively well with the normal blood pressure, FaO2 not very high, but there is definite pulmonary hypertension. Of course, all these babies are sick. I'm talking about among the sick babies, the relatively less sick infant has a normal blood pressure and an FaO2, maybe around less than 60%. That cutoff is a bit arbitrary. And you may have very sick babies with high FaO2 requirement also. And of course, really sick babies who are hypotensive, and you're in more trouble there. So I think we should kind of at least separate out the approaches to these babies when we are trying to manage pulmonary hypertension. It would be good to have some kind of a protocol because especially if you want to study a new drug, an RCT, because then you can make sure that the other babies, all the babies will get a standard treatment based on a protocol. And on top of that, you can study the new drug versus the placebo. Otherwise, it would be very difficult to study these drugs if there is no standard protocol. So, I mean, if we have, this is based on our current standard protocol, and if we have a normal blood pressure and the baby is not too sick, dobutamine is the drug that we usually go with first. And people use dobutamine in all these categories, but it's not really a tonic. So I wouldn't indiscriminately use it, but it's relatively safe, and it does seem to support the cardiac contractility and has some benefits without causing much hypotension. So I think it's up to the individual units, but I would suggest definitely that it's useful in a baby who is not hypotensive and has a relatively low FaO2 requirement. And then if that doesn't work, we go to prostaglandin E1. And the Milrinone study is currently going on. but Milrinone also is a pulmonary vasodilator. So one of these options I would suggest next. But in a baby who is sicker, let's say the FiO2 is more than 60%, I would say you need to be a little more aggressive. So inhaled nitric oxide, of course, we are leaving out of this discussion, like I said, but many units don't have it, and sildenafil would be the first choice for many of these units. And as we know, the only real problem with sildenafil is the risk of major risk is of hypotension, especially with the IV form. Actually, the hypotension is not anywhere as troublesome if you are using the oral form. So one option is you use the oral form. Another option is that you be prepared to give extra fluid if there is hypotension if you are using the IV form. Monitor aggressively. So it's not that you cannot use IV sildenafil, but you may need to monitor and be prepared to act if there is a problem. And before you go to prostaglandin or Milrinone. So, but if the baby is hypotensive, we need to act more aggressively to support the systemic circulation. Of course, you need to reduce the pulmonary hypertension also, but keeping up the systemic circulation takes the priority there. You need to restore the blood pressure before you do anything else. So in that case, you can consider a fluid bolus, 1 or 2. Some protocols say 2. I would say 1, unless there is a setting for hypertension. And then probably dopamine, there is not really only indirect evidence for that, because we know that dopamine does improve the blood pressure a little bit more than dopamine. So not much evidence again, but I would start dopamine before low dose vasopressin. So of course, these drugs can be used in different combinations also. But I would suggest that, because there is so much variability in practice, some units use more echo, bedside echo to guide their therapy. Some units don't. And some units have issues with availability of certain drugs. So your protocol is probably going to look a little different, but it has to be based on some reasoning, right? So this is what we felt was that was something that works for us. Of course, if you have inhaled nitric oxide, that actually may take preference over many of these drugs before that. We actually use almost all these drugs. Like I said, IV sildenafil we use as an infusion, and we also use oral sildenafil, definitely much more and then you might ask, what about norepinephrine or epinephrine and all that? I would say that that has to be, further decisions will have to base on echocardiogram, and it has to be customized to the baby. Each baby is going to be a little different. Standard treatment protocols can only take you so far. But the standard treatment protocols are still very useful, especially if you don't have a person standing at the bedside doing echocardiograms reliably for each baby 24/7, right? So I think that describes most of our settings. Based management for pulmonary hypertension, at least in the near future. So this is a very colorful summary written up by one of my friends, Jayashree Nair, and Lakshman Satyan from US. So they, I know it's somewhat too colorful maybe, but essentially the same things that we were talking about when you're managing pulmonary hypertension. The preductal saturation may be around 90 to 95 or 90 to 97% target. Controlled stimuli like noise and light and pain. Avoid paralysis. Make sure there's adequate inflation, but no hyperinflation. If you need too high pressures, maybe more than 25 PIP or so on the On conventional ventilation, consider high frequency. Keep the pH above 7.2 or 7.25. We try to keep the lactate under 3 or 4 millimoles per liter. Try normal urine output. Maintain systemic blood pressure at least above 35, but 45 would be even better. And use volume judiciously. Postrectal, we don't routinely follow, but above 70% would be good because your postrectal saturation is what your kidneys are seeing and what the bowel is seeing. So postrectal saturation more than 70% is acceptable, especially in diaphragmatic hernia. So that's really all I have for you. And we will have some, I think there are some questions already. I'll try to look at that and maybe answer some questions. Thank you.
Thank you, sir, for your presentation on pharmacology in pulmonary hypertension. I think the approach, there are a few questions on the approach as well. So we have the first question from Dr. Shashidhar, who asks that when nitric oxide is available, the protocol is still to start sildenafil first due to cost.
Yeah. I agree. Nitric oxide is definitely not cost effective. It's definitely not cost effective in a country like ours. In fact, one of the problems with nitric oxide, even in the West, is that it is so expensive if you actually have to use medical grade nitric oxide that you buy from the company. Of course, in India, we are using the industrial grade nitric oxide and reducing the cost and all that. But unless your unit has a fairly high volume of cases, it's going to be difficult to do calibration gases for that every 6 months or so and maintain it. So you have to, if you're in a private setting, I think you will have to pass on the cost to the customer also. So I don't know if it is that cost effective. So I think sildenafil is definitely worth a try. And of course, non-response, even if I had inhaled nitric oxide available, I agree with Dr. Shashidhar. I would probably give sildenafil a try before I go with inhaled nitric oxide.
The next question.
I think Dr. Pradeep has said sildenafil. Yeah, he shared his experience.
Dr. Pradeep, would you like to share your experience on that? Dr. Pradeep?
Hello.
Yeah.
Hi, Nishad. No, this is exactly what we also do, because looking at the cost that we incur, so invariably we end up starting with sildenafil, and the babies who have severe PPH and going on HDO, and then